The webinar will now begin.
Good morning, everyone, and welcome to the second of our webinars on navigating medical necessity. We're excited to have you all back, and we look forward to presenting to you today. My name is Jeff Schiff. I am a pediatrician, a senior scholar at Academy Health. I've worked extensively with Medicaid and with the Maternal Child Health Bureau and HRSA. So it's a pleasure to be moderating and participating in this webinar with my colleagues. Next slide. We're doing these webinars on medical necessity in a series of three. The first webinar, we discussed the definition of medical necessity and the use of evidence to create policy that defines medical necessity. Today, we're going to spend some time talking about Medicaid and EPSDT coverage, as well as the collaborative agreements between Title V agencies and their state Medicaid programs. And then we're going to start the process of the practical application of medical necessity and begin talking about the prior authorization process. Next slide. And next slide, please. Well, this is a little local for myself. I've moved to Utah, but I was very happy to note that Delicate Arch, which is the main feature in Arches National Park, or one of them, looks a remarkable amount like chromosomal banding with a centromere. So geology and biology have met in this state. So I hope you will keep going, but it was fun to find this. This webinar is supported by HRSA, the Health Resources and Service Administration, both from the Catalyst Center and from the National Coordinating Center for the Regional Genetics Networks. So we're very appreciative of that funding that brings this to you in a cooperative effort. Next slide. There is CME available for this, and we hope that those of you who are eligible apply. The CME is provided through the American College of Medical Genetics and Genomics and is accredited by the Accreditation Council for Continuing Medical Education. It is available for 1 credit, and we ask that you apply for these credits within 30 days of the date of this activity through the ACMG. Next. This is our incredible crew. You'll see everyone listed here is on the program committee. The presentation panel and moderators are here, and we are asked appropriately to look at if there's any financial relationship to disclose. And we will note that Julie Kaler is employed and is a part owner of Guardant Health, which is a authorization organization. So we'll move forward here. We have 3 learning objectives today. We want to explain EPSDT and how it sets a standard of care. We want to talk about the relationship of Title V to Medicaid briefly, and then we really want to get into the experience of the first steps of getting prior authorization done. And I'm sure that many of you have been in that world quite extensively. Next slide. Here is our crew that's presenting today. Myself, Julie Kaler, Demetris Nance. Nicole is not with us today. She's one of our other family partners, Aaron Beaver and Tammy Jones. Next slide. I just want to say that if you're interested, and we hope you are, if you were not able to attend our first webinar, the first webinar is available on demand on the ACMG website. And this is a link to it that we can also send out. Okay, next slide. We're going to spend the first part of this talking a little bit about EPSDT and Title V. EPSDT is early periodic screening, diagnosis, and treatment. And we're going to talk about three things. We're going to talk about EPSDT as the basis for determining medical necessity and coverage in Medicaid. And we're going to talk about, so we'll talk about who is eligible for Medicaid, about EPSDT and its definitions, and then again about Title V and Medicaid. So next slide. So a wonderful graphic put together by one of our colleagues at Catalyst Center. But EPSDT provides, as we'll talk about in a moment, the I would say the floor or the definition of what's covered in services for children in Medicaid. And there are 4 ways to become covered by EPSDT services. Through most children are covered through income, and it's a weird term, but they're called categorically needy or categorically eligible. And the income definitions are defined by each state. So each states have different definitions of who is eligible. Children can also become eligible through income and disability. Low-income children with functional limitations can receive supplemental Social Security income, and they can become eligible. Children with severe disability, which means that they have an institutional level of care, can be eligible through a program called TEFRA, which is an acronym that refers to a tax policy, or through 1915C waivers, or as mechanisms. And those children can get services that are a little bit separate from the income qualifications. And then finally, children in foster care in states are eligible. I will point out, because I think it's really important to note, that in the middle of the pandemic, for the first time ever, over 50% of children in the United States were in Medicaid. And I will also point out that Medicaid is most often the second highest behind education cost to state budgets. Next slide. So we want to get into EPSDT a little bit just to let people know about this, because it's a pretty important thing that has defined care for children in the United States for quite a while. Medicaid was started in 1965. And in 1967, EPSDT was defined to create a comprehensive set of benefits that supersede other federal or state statutory limits. And this is from CMS. I think it's important. The goal of EPSDT is to assure that individual children get healthcare that they need when they need it, the right care to the right child at the right time in the right setting. Next slide. The EPSDT definition states this, that states should also consider all aspects of the child's needs, including nutritional, social development, and mental health and substance use disorders. States are permitted, but not required, to set parameters that apply to the determination of medical necessity in individual cases, but those parameters may not contradict or be more restrictive than the federal statutory requirement. And I think this is really important because it's, which supersedes which is often in question, but this is a situation where the federal statute sets the floor. So what is EPSDT? Next slide. Here are the words in it. The first 2 are the when words, early and periodic, and the last 3 are the what: screening, diagnostic or diagnosis, and treatment. And we're going to talk a little bit about what's covered under screening services here. But I just want to, in just a sec, but I just want to point out that one of the things that is talked about EPSDT a lot, and we saw that just a couple slides ago, is when the children need it. So children obviously are going through a developmental trajectory, and children need certain services at certain times in order for the services to be timely. Go ahead, next slide. So in the screening section, it includes comprehensive health and development, physical exam, and immunizations, but also includes appropriate laboratory tests. I think there's an interesting bit of history that unfortunately has repeated itself recently, but that it specifically mentions lead toxicity. It includes appropriate laboratory tests. And next slide. EPSDT also includes enabling services that supports the children's ability to get medically necessary services. And these include things like transportation or services outside of state boundaries. Next slide. And I think if you remember, we can keep going. I'm sorry, I'll just say that that slide really just points out that it can't be burdensome to parents and families. So the cost has to be, cost sharing has to be limited, and that provider adequacy has to be looked at. And that's a big issue in Medicaid, is looking at the adequacy of providers, both in managed care and in fee-for-service Medicaid. But the next slide is really, if you remember anything about these 5 minutes, I'd like you to remember that EPSDT determinations must be made on a case-by-case basis. A hard stop policy to absolutely limit services cannot be created for children covered under EPSDT. So the policies that we talked about last time that were created are really guidance for how to apply evidence, but that evidence then has to be applied to individual cases. And this applies both to states and to MCOs. Alrighty, and then next slide. Moving off of EPSDT, I wanted to just talk about something that we've talked a lot about actually in the last year or so, as Title V sort of looks at its strategic plan, and as Medicaid, I think, looks more at its quality. And that's that Title V and Medicaid in each state are supposed to have a cooperative relationship. And this is really something I just want to highlight. That's not going to affect your individual letters of prior authorization, but it may affect how you work with your state. Title V and Medicaid are supposed to have a continuous liaison relationship between the two agencies. They are supposed to jointly evaluate policies and planning that affect each organization and their joint beneficiaries. They should periodically review their joint planning structures at a regular basis. And that includes how to access services and that the outcomes of services are monitored. And this should be a written interagency agreement. So I think that I bring this up because as somebody who's been in Medicaid and worked with Title V, I want to say that Medicaid has a whole set of priorities around long-term care and around eligibility, and it's usually a big budget item. And Title V can have influence, and this is the mechanism by which it can. And sometimes I think we need to define these and work on these in a better way. Alrighty, I'm going to go to the next slide, which is either a fossil from Southern Utah or DNA, and it actually is DNA, but I thought since some of these things look alike, we thought this was interesting. So now we want to just we're going to switch gears now and move off of the EPSDT and Title V and talk about the prior authorization. This is a slide that from Julie that I think is really very relevant, and just a very, very quick review of evidence-based medicine. This looks at the best evidence. This reminds us that we look at the best evidence first, and if the evidence has to be combined with clinical expertise and with patient preference and values, and somewhere in the middle is the best application of evidence-based medicine that improves outcomes and care of the children we all serve. Next slide. Today, we're going to talk about this first part of the authorization process, the request. And then at the end of June, we're going to finish up and talk about approvals and denials, appeals, both in Medicaid and in the commercial world. Next slide. This is sort of the cascade of how payers manage testing. And I circled prior authorization because that's today's topic. Coverage exclusion is not something, as I said, as a blanket thing that we do in Medicaid, but in private insurance, that can be the case. And then medical policy, post-service review, gold carding, appeals, et cetera, is something we're going to talk about in much more detail in June. So to prior authorization requests often require a standard process. The request, it's often, as we'll talk about in a lot of detail here, it's often important to find the policy that goes behind it. And we're going to talk about the specificity. And first, I'm going to turn this over to Erin and Julie to talk about how this is done and the great work that's been done at Heartland. And then we're going to talk a little bit in more detail about some of the specificity that we're dealing with, I think, right now when we talk about genetic testing. So it's a pleasure to turn this over to Erin and Julie at this time. Erin?
I'm actually going to let Julie start us on this slide.
Great. So the Heartland Regional Genetics Collaborative kind of came together, and we used our expertise to outline some prior authorization process quick tips. And this was intended to be a resource for the clinic. And I wanted to highlight some of the things that we as a group kind of troubleshoot and found to be the most helpful. And really, this is to impact and maximize the efforts of you guys as individual providers, and then also for our family and ancillary staff working on these prior authorizations or trying to understand the process, how to do that a little more efficiently. So whenever we see a patient in clinic, it's really helpful to know what insurance they have. That may seem obvious, but I think without awareness, some of our non-genetics colleagues may not always be used to checking this. And then, does their specific plan cover any genetic testing? Is it a covered service, or is it a plan exclusion? And then, is your facility or the laboratory you plan to send to in or out of network? The patient may not have out of network benefits, and that could be important to evaluate. And so if you are able to find out that there is a coverage policy for the test of interest, let's use exome as an example, and that policy includes medical necessity criteria, then you can kind of evaluate whether or not your patient meets that criteria. If they do, then yes, spending that time for a letter of medical necessity or going through the prior authorization portal is really a valuable use of time, and we can smooth the way for testing and reimbursement. If you notice that your patient doesn't meet the coverage criteria outlined in the plan policy, then you may have a couple of different options. One may be to highlight, my patient has a set of symptoms or a case scenario that doesn't align with policy. In fact, your policy is inadequate to address my patient, and so should be approved on an exceptional basis. And go ahead and make that argument. Whereas if it is purely not going to meet medical necessity criteria, then there may be other options for you to pursue. And a letter of medical necessity might not be the most efficient use of your time as an individual provider. And if there's not a coverage policy or your patient doesn't meet coverage policy, there are in fact a lot of things you can do. Collecting case specifics and tracking them, and then maybe bringing that up to a higher advocacy level, get your government relations group at your facility involved, enroll the patient in research or explore sponsored testing options. And of course, if testing is still a necessity at this time, advise the patient that right now it looks like it's not covered, but we can do whatever we can do on the back end. So we just wanted to put together something that was a quick guide to individual providers to help them use their time most efficiently, and of course, make impact and change for the patients. Next slide.
All right. So one of the pieces of the toolkit that you'll find, and there is a QR code, as you can see at the top of these slides, where you can actually go to the toolkit on Heartland's website and explore that further, because there are more resources than what we're showing today in our presentation. But this one I think is very valuable for offices, for providers that are maybe not used to doing their own prior authorizations that can come up around genetic testing. But also it's very informative for families to help keep them on the same page, which can alleviate some of the stress and frustration that families can get during this process, because it can be a lengthy process. It can take time to move through it. But when you're needing to perform a prior authorization, the first thing that you want to do is gather all of your information. And there's a couple of pieces of information that you'll need to have. This is to avoid your own frustration if you're the one doing the prior authorization. So you'll need to have your patient's demographic information and insurance information, which is probably the most obvious. But we do also need to have the CPT codes for testing. That's usually available at the laboratory website. There are some labs that do not post their CPT codes, but you should be able to call them and ask for those codes. Once you've got your CPT codes together, if you have common tests that you're ordering, I do think a helpful hint here is to make sure that you have a copy of those common CPT codes that are ordered in your office, kind of keep them together where anybody who's running these prior authorizations could have easy access to them. That's going to save you time in the long run. You'll also need to have your ICD-10 diagnostic codes for the patient. I will let you know that some insurance payers are only going to allow you to use one or two of those. So make sure that if you're the provider and you're not the person who's filling out or doing the prior authorization, make sure you've prioritized those in a specific order of what's most important or most compelling, the largest reason why you're doing this testing, and you've in some way communicated that clearly to your staff that's doing this. Otherwise, if you use a less important code for that patient, it may cause a denial in the long run. So make sure you've prioritized those codes appropriately. You also want to make sure that you have your ordering provider MPI number, the laboratory MPI number or tax ID number if you're not using institutional billing. And I know that I would say these days, the vast majority of genetic testing goes out as not institutional billing, although obviously for inpatients, it is institutionally billed. You'll want to save, again, another helpful hint here, you'll want to save your MPI or tax ID numbers for the labs that you commonly use, so you're not having to look that information up all the time. The last piece of information that you'll need is your clinic notes, along with the pedigree or family history, if that's available. A really good tip here, I'm going to call it a pro tip on your clinic notes. Julie mentioned being familiar with the payer criteria for testing, what they cover, what they don't cover, and why they cover it, and what circumstances they cover testing. Be familiar with that for the payers for your regional area, where the common payers that are coming into your office. That way you can write your notes to the most stringent of those criteria for every patient, and then it doesn't matter really, otherwise you're putting everybody to that same high standard in your clinic notes. And especially if you're not doing your own prior authorizations and it's somebody in your staff, then they have everything that they need to be able to complete this process. And it's very clearly outlined, because many of the support staff that are doing these things do not have, the training or background to really be able to supply that information if you have not supplied it. So that's a helpful tip there, and this will avoid your staff having to do extra work, or it could even avoid having to do appeals if you have all of this information, prioritized appropriately and there in the clinic note. The next thing that you'll want to do is to call the insurance provider and ask what's their process for prior authorization. Do they require a prior authorization? Every payer is different. And so some are going to have letter of medical necessity that you have to submit. Some are going to have a phone process or an only online process. Others may have a special form. I would recommend, again, saving that information, the process for each of your common payers in a file for your office, so everybody has access to that and you're not having to recall the insurance company, because we all know that, sitting on wait for a call is time consuming, and it is also frustrating for some of us. So if you keep it all together, you don't have to call every time. The next thing that you'll want to think about here is if you're going to have to write a letter of medical necessity, What does that entail? And we're going to talk about that in the next slide. Before we go to the next slide, I will point out that there are some payers that may require a peer-to-peer review between the provider's office and provider on their end, and that's a conversation. So know that that's what that means, and it is in some circumstances required. And the last thing that you'll want to do when you're actually talking to the payer office is ask about the time frame to a decision. Every payer has their own time frame, and you may be expecting a quick turnaround when in fact it may be like a 30-day turnaround time for that. So make sure you know what that time frame is and ask how they're going to notify you. Next slide. All right, and so this is actually a lot of the information that you need in your prior authorization call is things that you're going to need in your letter of medical necessity if you're required to write a letter of medical necessity. So obviously the patient name, date of birth, their demographics and their insurance information should be at the top. The next thing that you want to make sure you have is the patient health information. So you want a clear statement, and I really do mean clear as you can get about the patient's clinical presentation, their family history if it's applicable, and what's the differential diagnosis here? What are the things that could be explaining these symptoms? Then you're going to want to give the test information. So that would include the name of the test, the CPT codes, again, the laboratory information like tax ID or MPI if you have that, cost if you have that. And then if you have any statements from organizations like ACMG or NSGC about the validity and utility of the testing, that would be nice to include here as well. The last thing that you're going to want to have as a major element is why the testing is important, and I would argue that this might be the most important piece of the letter of medical necessity. But you're going to want to include a clear statement about how the results would affect the patient care. I think many of us assume that whoever's reviewing these cases on the payer side knows this information, but they may not, and so it's very good to outline this. So you want to include any possible changes to medical management, any avoidance of unnecessary testing that this would allow us to know about. It would any information that is relevant to the health management and health planning for the rest of the family. I think that it's also valuable to have how testing information could affect psychosocial support, educational support, social support, that kind of stuff, or interventions for this patient. And then if applicable, you would want to detail any harms that could occur if testing is not pursued. And I would end this element with that statement. And then don't forget to provide your contact information so that if there are any further questions that they know who to contact.
And Erin, if I may just add a plug as someone who used to review prior authorization requests, the best letter of medical necessity is really specific to that payer policy, because that's what reviewers are using to determine whether or not it's going to meet criteria. So if you can show how those criteria are met, you can really get by with a lot less time spent on writing. And then let's avoid phrases like this will change medical management. Instead, as Erin so aptly put, describe how you might anticipate that. Or parental anxiety. That's not necessarily something that's going to let us approve a test, but if you can count to or point to any changes that the family may pursue, then that can be a really helpful factor in our decision. Thanks, Erin, for letting me jump in there.
Yeah, no worries. And if you do go to the toolkit, there are examples or templates of letters of medical necessity that you can use. Next slide. So, next slide. There we go. So we thought that this would be a good place to bring in that diagnostic case that we talked about in the first presentation. So just as a reminder of that case, or for those that were not able to attend the first webinar, our first diagnostic case is a 5-year-old male with global developmental delay and autism. He's had a history of 3 seizures, 1 at age 3 and 2 at age 5. And he's already had Fragile X testing, which was normal. That was with his PCP. He has had some frequent respiratory infections and was found to have an immune deficiency. And he has a family history of autism and developmental delay, as you see here. So he was seen in medical genetics where they did a microarray, which was normal. And now it's time to do a whole exome sequencing. Next slide. And so really for this test, many insurance payers do require prior authorization for an exome sequencing. And what we're going to gather for this patient are his patient demographic and insurance information. We're going to gather the CPT code for whole exome sequencing. These days it's generally 81415, but it can be lab specific, so make sure you look that up. I have provided the diagnostic codes based on the family history and personal history that was described for this case. And I tried to prioritize them best as I could. And usually your family histories are going to be lower priority unless it's a family history of a genetic condition. So most of your Z codes will come at the end of a priority list of ICD-10s, again, unless it is a family history of a specific genetic condition. Then we'll have our provider MPI number, laboratory MPI number. And again, don't forget to make sure that your clinic notes are very clearly outlined to the most stringent payer test coverage policy for the insurance payers that come through your office. And next slide. So we find out from our phone call with this particular payer that we are going to have to write a letter of medical necessity. And so this is the letter of medical necessity that we have provided to the insurance company. Obviously, things like HPI are left out of this. But one thing that I do want to point out, and I think we're going to be talking a little bit more with Dr. Schiff, is here I've provided as part of the justification for this testing, the American College of Medical Genetics recommendations from July of 2021, their practice guidelines on exome and genome sequencing. As it relates to children with developmental delay and or intellectual disabilities. And that's the end of my slides. I'll turn this back over.
Thank you very much for that. The meat of this about how to actually get this accomplished. I want to just spend a little bit of time talking about what I guess I would say is the challenge where we're at now. And if you go to the next slide, I want to point out this wonderful map, which is, if you go to the website, is live, so you can actually hover over your state or the states of the children you care for and actually see what their Medicaid coverage policies are. But I guess I want to get into a little bit of this because everything's open to interpretation, right? You know, and we spend a lot of time in our human world talking about language. And right now, I just want to tell you that I think, especially with whole genome sequencing, we're really at this kind of challenge around medical management versus clinical outcomes. And I just want to point this out because I think we're seeing it right now. I did there are really probably hundreds of policies to look at, but I took one of the prominent Medicaid managed care organizations and sort of dug into where they're at. This is what they say. This is whole exome sequencing. So it's around, and sometimes I'll just tell you, and this is where we go back and forth a little bit, is whole exome sequencing and whole genome sequencing are kind of confused in some of these policies or put together. But diagnosing or evaluating genetic disorder when the results are expected to directly influence medical management and clinical outcomes, and the following criteria are met. So this is a criteria which I think Julie and Aaron really talked very specifically about how to address. But when you go back to the policy, if you go to the next slide, part of their policy when it looked at whole genome sequencing, looked at Hayes. And if you remember last time we talked about Hayes as one of these vendors that produces clinical criteria that are often used by Medicaid folks. And it said that with regard to whole genome sequencing, that the evidence is insufficient to support whole genome sequencing to inform clinical actions or improve outcomes. And this was specifically in the same children that if you look at the next slide, the ACMG guideline recommended that exome sequencing or genome sequencing as first or second tier. And the ACMG guideline goes on to say that talk directly about costs. And I think I just want to mention that while this is talking about evidence. The evidence is always related to what the cost is to do this, because if the cost is really insignificant, nobody tracks or authorizes CBCs, for example, or metabolic panels. We authorize expensive things. And if you go further, then I just want to go further into what the guideline, if you go to the next slide, the MCO really talked about the fact that there was no, and this is a study about whole genome sequencing that was done fast versus slow in the NICU. So 15 days early group versus a larger group. And it does, when tests are expensive, managed care organizations get into this level of detail. And it says the study showed no measurable difference in length of stay or survival, which is the outcome part. The relevance of the study on clinical outcomes is unclear and was not examined in the study. However, the paper's abstract directly addresses this. Instead, it said that in this randomized trial for acutely ill infants in the intensive care unit, whole genome sequence was associated with a significant increase in focused clinical management and actually create an opportunity for diagnostic equity. Next slide. I bring this back around because I want to remind folks that what we talked about earlier, that EPSDT really says that what's covered in Medicaid are tests to follow up or rule out or confirm when screening identifies a risk or a potential problem. So I think that we have this conflict that if it's not approved in the first line, this gives us a window to how to approve something or ask for something to be approved downstream. Next slide. But I want to talk about something probably a little bit philosophical, but I think that's really important. I want to, as having been involved in Medicaid and as a Medicaid medical director, the Medicaid programs, and I think for the most part, I'll say very clearly, the health plans that serve Medicaid recipients want to do the right thing. But there's always this tension between what actually is being, what actually people are working for and whether it will actually provide important clinical services. So I'm going to go back to something that I talk about a lot, and that's that if you can create a relationship with the health plan or with the Medicaid program and the reviewers to understand where you're coming from and who you're serving, you have a much better possibility. And I guess I would also say that in Medicaid, because it happens so frequently, there's a commercial interest that can occur or that can come along either to deny things or to get tests approved more frequently. And those interests certainly are weighed by the Medicaid provider and the Medicaid agencies to say, is this something that is really going to benefit these patients, or is this something where the commercial interest is just pushing it? And we see this. I could give a lot of examples. Anything from wound vacs to hepatitis C treatment. That people come along and say, if we can get Medicaid to approve this and approve it frequently, we'll make a lot of money. So I think that you have to come along and say that you have some specialty that's worth paying attention to. So I really encourage finding a way to build a bridge to the folks who are reviewing the letters. And if you have a prominent Medicaid managed care organization, or if you're in a fee-for-service state, to ask for an opportunity to meet with the Medicaid medical director or their staff to talk about these letters of medical necessity and how medical necessity is reviewed and who is reviewing it. And then if you do that, I encourage you to document the decisions and assignments from the meeting. So someone may want to know who on your side's writing the letters and what criteria you're using. So I think you could do that. You could document your expertise, that you're really looking at this as a geneticist or a genetic counselor. You can, and this is something we'll talk more about next time, ask for fast track coverage. And a lot of the policies, even the one that I just went over from a health plan, look at genetics providers being involved so that you don't have someone who's not qualified just deciding to ask for genetic testing on a regular basis. And it often goes to genetic providers. I'll also just give a plug for developmental pediatricians who often are asking for this as well. And then the next things I think are really helpful: create an ongoing relationship, if you can, with the managed care organizations. Be willing to tell them about who you're requesting genetic testing on or other services, because we're going to talk about other services in just a minute, and share data back about what your patients are doing and how these tests altered or did not alter care. And also be willing to share this documentation with the state. If you're working with specific managed care organizations that have a big part of the business in your state, feel free to go back to the Medicaid or the Medicaid medical director and share what you're doing with the managed care organizations specifically. And if you do this, I think what you really find is that they're receptive and they really want to be helpful. I think everyone has the same goal of helping the children in the state. Okay, next slide. We're still in the same theme of geology and biology, and we're going to just turn to the therapeutic case, but can you go back just for a sec? I just have to tell you that down in southern Utah, there's this beautiful, I think this is the most extensive set of pictographs I have ever seen in my travels around cliffs of the, but these are 2,000 years old. I think you could look at this as somebody starting to draw the phenotype of their genetic family diagram. And I think it's a beautiful thing. And I encourage you to ride on this 30-mile dirt road to see these if you're ever in this part of the world. I'm going to turn now to Tammy, who's going to really take the therapeutic case we started last time and talk about how to work through the medical necessity process for this. Tammy?
Thank you, Dr. Schiff. So in our last webinar, we did touch on this therapeutic case, which involved an adolescent male with PKU. And this patient was prescribed Phoenix 2 medical food, 17 cans a month. And as you can see, it was quite expensive. The patient was insured under his parents' employer's insurance plan, and a medical food prior authorization was required. Next slide, please. The first step that you'll take when you want to get the prior authorization is obviously to do a benefit inquiry to check the insurance benefits. I won't go over all of these details because they were covered in our previous slides, and we'll move on to the next slide. When it's time to do your prior authorization, there are some elements that you will undertake. First of all, obviously, you'll contact the insurance company. You'll provide that insurance company with the physician's name, NPI number, the office address, and all of the demographics so that they're able to contact you and reply with a decision. You will provide the patient's insurance information, ICD-10 code and diagnosis is what they'll also need, along with the healthcare procedural coding system code that is specific for that particular medical food. You provide the name and NPI of the service provider, and medical food is most often provided through a durable medical equipment company. There are rare occasions when the pharmacy benefit will also cover it and the patient may get it from a pharmacy, but again, it's most often obtained through a DME company. You will document any prior authorization or reference number that they provide to you, and also the name of the representative that you spoke with. Often the prior authorization will not be given immediately. In some cases it's possible, but there will be a turnaround time. So you'll want to ask them what is the turnaround time for that prior authorization and ask how they will communicate that decision to you. You may also, once you get that information, provide it to the DME company. DME companies often have their own reps doing this as well, but on some occasions, it's good for office staff who are working on a dietetics team to get that information, just to kind of move the process along a little quicker. Next slide, please. With the medical food authorization process, you'll want to gather some important documents and have this information readily available. You will get the medical food order, which will obviously have the patient's name and date of birth, the name of the particular medical food. It's important to include the route of administration. Some DME companies will be able to service a patient maybe only one route of administration. It could be tube feed only. And that's always dependent on the contracts that they have with the various insurance companies. So you'll definitely want to indicate that on the order. Include the ICD-10 code along with the HCPCS code for that particular medical food. Provide the letter of medical necessity, very specific physician clinical notes, as well as the dietitian's note, which will have all of the information regarding their dietary reference intake, the fluid requirements, current medications, and it's important as well to include the percentage of sole source nutrition as well. You want to include their compliance history with their diet, nutrition assessment, any counseling that was provided, and any intervention and plans for the future. You'll also want to be sure to have the DME contact information, demographics, as well as their NPI number. Next slide. Well, let's stay right there on that slide, actually. What we've done at Emory Clinic is make sure that our clinical note templates mirror some of the important information that is needed in order for medical food to be approved. So if you have a relationship with your electronic medical records administrator or someone in your organization who is able to create those templates, it would be beneficial to make sure that those elements are in place so that when the dietitians and physicians are creating those notes, they capture all the necessary information. And it just makes the process a lot simpler. Next slide, please. And I will now turn it over to our next presenter.
Great. Tammy, thank you very much. And I think that some of the things you just said really about the electronic medical record and making sure everything's in there, I think that's a great way to make sure that that this process is streamlined, saves time, and then the people who are coordinating the input have what they need. We want to just now open this up for some discussion in the last 13 minutes we have, and really talk about this authorization process, both from family and provider perspectives. So we welcome questions, but I really wanted to ask Demetrius to join us for a little bit and talk about this prior authorization process from the family perspective, because we know that this can sometimes be challenging, and it's a process that even those of us who understand it sometimes spend a lot of time in. But for families who have a child who they're trying to who they love and they're trying to help figure out what's going on, this can be a challenge. So Demetrius, are you on, and can you will you chime in here and talk about some of these family perspectives on prior authorization?
Sure. Thank you very much. As a family and as a parent, most times we're looking forward to seeing our doctors and also adhering to the orders of our providers. So I've participated in a lot of prior authorizations. Most time I've received a letter from the insurance company stating that they either have denied our services. And once I get that letter in mail, the first thing I do is contact my provider and share with him or her that this actual procedure or medication has been denied. And oftentimes he referred me to the clinical team who is actually responsible for completing the prior authorizations process. I spent many days and many hours on the line talking to insurance company because I'm, adamant about getting this medication or this procedure for my child. So I've had a lot of good experience. And also, most times the process can be delayed due to the staffing of the doctor's office, or the staffing is doing multiple tasks But the good experience that I've had is that the office that I attended had a dedicated person who actually only did prior authorizations. So therefore, that particular person had the time, had the patience to actually make sure that the prior authorization was done in a timely manner. What advice do I have for families? I can give you a whole lot of them, but the most important advice is that for the family member to take an active role in the process. Take an active role in the process. Ask your provider or clinical staff to explain the process to you. And most time when you hear denied, you thinking that you can't have it or it's not available for you. But there is a process that only need to just be explained to the patient. Check the details of your insurance policy. Most times we do not read our insurance policy. We just get the card and we just go from there. But most insurance policies are now online, so you can read them at your leisure time. Lastly is if you ever received an authorization that says that the authorization is denied, don't think that's the last step. The first time, do not give up. Go to your doctor's office, ask them if an appeal, and sometimes you can contact your insurance company to initiate an appeal on a denial. But most of all, what I think that the providers can do is just communicate back with the family in a timely manner. If they experience a lot of prior authorizations, whether it's for a procedure or a medication, have time to either meet with the particular insurance company to see if they can do something, add additional clinical information to make this available for the patient. Thank you.
Thank you so much, Demetrius. And I would just love to add, as a clinician, and I'm sure Erin can expand on this, I see this very much as a cooperative team process with families. And one thing that families can do to support this process is also just kind of check in and be forthright in how important this is to you and your family. If we decide that we're living with a presumed diagnosis and that's fine for us, we've got support, we're getting appropriate management, this would just be confirmatory. And for our family, maybe it's not worth chasing to the end of the world, then we can all make that decision together. But I think we as providers feel the need to fight for every patient. And so it's really helpful to know where you guys stand on that as well.
Julie, go ahead.
I was going to say, I completely agree with what Julie said, that this, there's communication and there's relationship. And I know I said it in our working group, but I'll say it here too. I really think that there's really a triad model here. So a lot of the pressure of communication back and forth gets put on the provider and the patient or patient family. But really there is a third entity in this relationship, especially when it comes to insurance coverage and testing, and that's the insurance company. And sometimes what we get is the paper from the insurance company, and we don't really get the conversation, so we forget that they're part of the conversation. And I think we need to find ways to invite them into the actual verbal conversation more than what we're able currently, and hopefully they would participate in that too with us, because it really is that all three of those elements, that we're stakeholders, right, together in trying to find the best care for that patient.
So all three of you, Erin, Julie, and Demetrius, I just want to ask a question of you, because Demetrius, you said, I think, something that I think about taking an active role in the process. And I think as a pediatrician and also from my side in Medicaid, I think that families, and I think this gets into Nicole's comment that came into the chat, how do you start to support families to take an active role? I think, and Nicole's comment, which was really about the family-to-family resource centers that are in every state. But I do want to know if you have any tips that have worked well in your clinics, or that you find, oh, this was the person who got the families to understand the process.
I mean, I think that one thing we have to remember, both from a provider standpoint and from a payer standpoint, is that the families that we're working with here are oftentimes in a mode of survival. And as much as we would like them to be able to have the capacity to take an active role, it may not be in a moment of crisis, right? Like if we're talking about a medically complex child who's in the hospital, that's probably not the right time for them to take an active role, right? So, but I do think that we can help to foster them taking an active role as time goes by. And I think it depends on what that particular family's needs are, how that takes place. I think the genetic counselors and the providers, as in medical geneticists or specialists or primary care, can help to facilitate that. If you're working in a situation like with them, where there's medical formulas, medical food that needs to, there's usually the dietitian is a common person that helps to facilitate, I think, a lot of that in the families. And social work. So some clinics do have a social worker. And that's another great person that can help to facilitate getting families to be more involved in the insurance process and the prior authorization process. And I think also from a payer perspective, many payers have the case managers, and that's another great person to help them, take ownership and be more involved in the process.
Thanks. Yeah, and I always think that as a pediatrician, there's an evolution of that involvement that starts. And I think, Erin, you're really right. If there's a right time to get the families more engaged in this whole thing, and it's not when their child's in the ICU or there's something else going on. I think Allison put Nicole's comment in here, and I think we highlighted it. I think the family-to-family resource information centers can be a really good support, and both emotionally and with some of the logistics of this. Does anybody, I think we've talked about how the families work on this. We had a couple other questions that I think we want to mention, and Julie, you answered one of them. If I can ask you, it's really about how to find these policies, and maybe you could just speak to that as well. We have the map up there, but I think there's also this issue of how to find the policies in managed care organizations. So go ahead.
Yeah, no, absolutely. I kind of think as soon as you start in clinic, or if you're in clinic and you really want to wrangle this process, it's really helpful just to have a cheat sheet for your most common health plans that you see that your patients have, and then go to their website or call and ask a representative to help you find the medical policies that you're looking for that apply to the most common tests. So at Arkansas Children's, when I was in clinic, I had Arkansas Medicaid and a handful of commercial payers, where I had their exome policies, their microarray policies, and like a general genetic panel policy kind of all saved. I understood those criteria, and I knew this one requires prior authorization. This Blue Shield won't do prior authorization, but they'll do a courtesy review that's non-binding. So there are some really good things that we can do to kind of reduce the work. I think all of our efforts here are to improve access to genetic testing. And my fear is that we're going to lose a lot of access if we lose our genetics providers. I would love to streamline and make these process a little more efficient, and then give you guys, permission to make this process more efficient, and then also not do things that maybe you did in training, but not write that element if it's not going to be impactful for this specific case. Instead, maybe we can save our thoughts and energy for impactful areas.
Dr. Schiff, can I ask you a question?
Sure.
Do you foresee a point in the future where the cost of genetic testing has come down enough that the payers would no longer require a prior authorization process? And if so, like, what's that point? Because I think that's something that all of us providers in the world would like to know.
That's a great question. I will tell you, that I'll just say in Medicaid, the Medicaid medical directors sit at this juncture of cost and quality. And so I have to, this is a tiny aside, but well, I used to say that if something cost $100,000 and it was going to be medically necessary, Medicaid's an entitlement program, so it's going to pay for it. The irony is then hepatitis C treatment came along, and it did cost that much. And it was that expensive for a long time. And then the cost came down to like $23,000 or $24,000. I think the answer, Erin, is it really depends. I think if something gets down to a reasonable cost, and I don't think there's a perfect number here, but it's going to be cost times volume, because you don't want to say, okay, it's now $500 to do whole genome sequencing, but the error rate's higher because we're using Joe's pretty good genome sequencer, and that's causing a problem. Or that now that we have that, everybody is going to their pediatrician and asking to do that test. So I think there's that balance that we have to look at. And it's really a matter, I think that's where Medicaid struggles. So I'm giving you a little bit of a non-answer, but I also think that what I think the Medicaid programs, I want to say, really want to do this well. And they really want this to be effective. So I don't think that there'll be a problem with getting it authorized as the price comes down. It'll actually become easier, but I also think we have to be cautious about whether somebody from industry comes along and says, you should get this done so you could figure out whether you have the BRCA gene because you can get it done as a kid, or something like that. So I think that's really important. I just want to say that I'm looking at the chat, but I'm not really able to read it. We'd like to hear from you all about what you would like to talk about next. We have one more session, and it is on June 29th at, I think is 1 p.m. my time in the Mountain Zone, or is it 1 p.m.? Oops, I'm just going to look here for a sec. It is 1 p.m. in Mountain Time and 3 p.m. I think in Eastern Time. Is that right? And then we'd like to hear from 3 p.m. Eastern Time. Great, thanks, Allison. And then we'd like to hear from you both about whether these webinars are meeting your needs, and if there's something you'd like to address in the next one. I think that we have some questions about specific about that, but our plan for the next webinar is to really talk about what happens after this initial prior authorization and talk about how to make this this more effective. So we will look forward to planning that, and we'll look forward to your engagement in that. Any other questions we have from folks? We're a little bit over time. This has been a pleasure to be with all of you. I think we're signing off. So thank you very much, and we'll look forward to seeing you in a little over a month.